A midnight nightmare at 3 a.m., a case coming with acute coronary syndrome with subtotal unprotected left main. 32 years old female without risk factor coming to our CCU, our hospital, with severe chest pain and cardiogenic shock. The terminal called me to see the case as soon as possible. ECG, V1, IVR, ST elevation, and diffuse ST depression with recurrent VT and VF. Bedside echo done, ejection fraction about 30-35, anterior, anteroseptal, and lateral wall hypokinesia with moderate MR. After talking to the family and the patient, we decided to take the case as soon as possible to cath lab because she was acute coronary syndrome and hemodynamically unstable, to do as much as possible to her because she's very young and midnight and with no risk factor. Right coronary angiobilateral approach going dominant, no significant lesion. But if you look to left system, there is subtotal heavy thrombus burden left main. We decided to proceed as soon as possible to take wire and do left main PCI. After taking the wire, whisper wire, left main become total and the case become arrested again and CPR started and total left main. The case very unstable, pulmonary edema, she's very tired, very young lady, 32 years old at midnight. We took ballooning by Maverick balloon 2.5, 20 after multiple inflation. Still left main is total and the case tired and recurrent VT, VF, CPR continue. We have no choice. We decided to, as soon as possible, to return flow to left main and left system. We take a resolute integrity stent 3.5, 26 from iliocranial to precise ostial left main positioning stent and do stenting for left main LID. After stenting left main LID, TIMI-flow 3 return to LID. But if you look at caudal view, there is subtotal and the case is still unstable, pulmonary edema, and recurrent runs of VT. We do ballooning for LCX really, but after ballooning, the LCX become worse and not improved. We have no choice. We decided to bail out stenting to left main to LCX. Really very, very difficult to crossing the stent and the case very unstable. After crossing the stent by tap technique, we do stenting to LCX, we do a final port and the case put on intra-aortic balloon pump because at our cath lab we don't have ECMO, we don't have any type of support system, circulatory support system, and only we have intra-aortic balloon pump. The case final result on intra-aortic balloon pump become better and we transfer her to CCU on ventilator and intra-aortic balloon pump and vasopressor. After 2 to 3 days, she become better. And after 10 days, we discharged from hospital. The case now from 6 years, she's stable, ejection fraction about 40, but anteroseptal wall hypokinesia, mild MR. She's on antiplatelet, rosuvastatin, anti-failure treatment. Really, we suggest for the case to do a control angio for her, but she refused it and she decided to never take her to cath lab. And she's stable really, and compensatory heart failure, and everything, it was fine. Take home message. IVR ST elevation with multi-lead ST depression indicate large area of subendocardial ischemia, either due to left main or proximal LAD or triple vessel disease or sometimes due to cardiogenic shock. In unprotected left main occlusion, 85% has cardiogenic shock. In unprotected left main occlusion, if arrived early to cath lab, available hospital can be opened successfully in 90% of cases. In unprotected left main, in hospital death rate about 60%, but 6 month additional MICE rate about only 9%. Thank you.